Okay, well, he's back, Dr. Anthony DiGiorgio, who claims he's a neurosurgeon. I have no clue. Can you confirm that you actually are a surgeon?
Neurosurgery is my day job. Policy and advocacy is my night job. I also do some work for the NFL. That's my weekend job. But I swear I do spend some time with my family as well.
And you have a podcast, which, by the way, for the record, I'm a big fan of, and I do listen to. It's, some bunch of doctors bitching about life, I think.
Hopefully, we're a little more nuanced than that. But yes, thank you for listening. Our podcast is The Doctor's Lounge.
Yeah, well, you've got Anish Gokal on that, so we know Anish. But no, thanks, Anthony. All seriousness, I taped a podcast with you on Medicaid expansion, which was really well received because I think one of the great things that you do, you give us a bit of a history and you give us a little bit of background about this, and then you have mix between your own opinions, but you also have data to back some of the opinions you have. But we've decided to talk about some program that the government has that supposedly is going to help the indigent folks and so forth. Before we do that, just a background on you, because some folks may have not listened to the prior episode, just so they know who you are.
Of course, happy to. I'm a practicing neurosurgeon, faculty at UC San Francisco. Of course, these views are my own and do not represent my institution, but I largely practice at our county hospital, San Francisco General Hospital, where I have majority of my patients are Medicaid or low income. It's county hospital safety net. And so because of that, I've really taken an interest in how the safety net is funded. A large portion of that is Medicaid, which we spoke about last time. But a large portion is this lesser known program called 340B. And the more I dug into this, the more interested and aghast I became at what this program actually is.
So let's level set. When did this program start, and what was it designed to do?
So the 340B program was enacted in 1992 legislatively. And the purpose of the program, as stated in the legislation, is to stretch scarce resources for what are called covered entities. So these are different healthcare facilities that, once they qualify for 340B, can purchase outpatient pharmaceuticals at a large discount. We're talking 50+% discount off of the average manufacturer price. So the original program started with about 50 institutions. It was things like federally qualified health centers, critical access hospitals, Ryan White AIDS clinics. And then hospitals could qualify for the program by meeting a disproportionate share threshold, which is a complicated formula, but it's basically how many of your inpatient days are occupied by Medicaid or dual eligible beneficiaries. So originally it started as a pretty small program that was meant to help these safety net facilities to stretch their scarce resources by being able to acquire these drugs at a discount. And then when they sold the drugs, they could gain spread on that discount. So if they bought it at 50% discount, they sell the drug at its average sale price. They could keep that spread as revenue. And that's how it's supposed to augment the resources for these safety net institutions.
Was there any mandate into how they actually spend that extra money they're making on the profit margin?
No, so there's no mandates and there's no transparency mandate as to what the institutions do with that money. And that's one of the problems with the program is that hospitals have now realized that they can treat this program as an ancillary revenue stream. And there's actually some really good data that as the program has grown now in the modern age, that started in 1992, now in 2025, most of the institutions that make money off 340B are actually not using those funds to put back in the community to expand service lines to underserved patients, but they're using it as investments. They're using it for capital acquiring of other practices, other hospitals, and they're reinvesting it into their funds to make money on investments. So they're really not using it to expand access of care to the lower income and underserved patient populations.
And who selects the hospital again? Is it the government, or you as a hospital need to apply to be part of the program?
You as a hospital apply. It goes through HRSA, Health Services Resource Administration. And so once you apply, again, it's if your hospital meets this DISH threshold, then you can apply. And not only does your hospital qualify, but every child site within your system. So if you are a large hospital conglomerate that has child sites across the US. All that needs to happen is one of your institutions needs to qualify, and this discount would then be available to every child site, every affiliate within your system. So, as I said, it started with about 50 hospitals. Today, if you include all the child sites and institutions, there are about 60,000 covered entities listed on the HRSA website.
Okay, so I mean, the program obviously, it appears to me from what you're saying, has good intentions. So what went
It
wrong?
does. I think it had great intentions, but part of the problem is again the incentives are misaligned. So once a hospital meets this threshold, they're actually disincentivized from treating more poor patients, right? Because once you qualify for the 340B discount, you make your most revenue by reselling those drugs or transferring that discount so that you are making money off of wealthy patients, right? Because reselling the drugs to a Medicaid patient or a poor patient is not going to generate you a large amount of revenue. Reselling it to wealthy patients generates more revenue because they have private insurance and so they can charge more for the drugs. So the incentives are totally misaligned. You're actually disincentivizing these institutions to treat more poor patients once they qualify. And there's plenty of data out there that shows that once hospitals qualify for the 340B discount, they preferentially open child sites and contract with pharmacies in wealthy insured neighborhoods, and they actually reduce the amount of charity care they provide and shut down service lines that are less profitable.
But isn't there, I mean, in any program, isn't there a process that once a year you get audited or somebody looks at whether you're following the program and then you can actually lose your certification?
All that needs to happen is you need to continue to meet that dish threshold. Again, just one site needs to meet that dish threshold, and that's the only thing you need to do. You don't need to show where these funds are going. You don't need to show that you haven't been abusing the program. All you need to do is maintain that dish threshold. And again, if you think about how you qualify, right, it's an inpatient metric. So the dish threshold is based on inpatient metrics, is how many of your total inpatient days are occupied by Medicaid or dual eligible beneficiaries. So you're actually not even incentivized to open up more clinic access for Medicaid patients, right? Because what do Medicaid patients do when they can't get clinic appointments? They come to the ER. What happens? They get admitted. That takes your dish percentage up. So you're actually disincentivized from even opening clinic space for access to low-income patients because you want those patients coming into your ER so you can get the admissions, so you can get your dish percentage up and maintain that while making sure that all your clinic space is available for wealthy insured patients who then you can then resell the drugs to and make this large margin.
But is this a theoretical concern you have, or is it actually happening?
No, there's plenty of data. There's a number of studies out there that have shown that these facilities will open up clinics and child sites in wealthy neighborhoods. There's a wonderful study that showed the distribution of hospitals and what their dish percentages are. You would expect, a normal distribution, right, where some hospitals have very high dish percentages, some would have very low, but that's not actually what happens. Is you see a cluster right at the dish cutoff to qualify for 340B. So it looks like a lot of hospitals will purposefully hit that dish cluster cutoff and stop seeing more poor patients after that. It's a really elegant study.
Interesting. Okay. When did this start happening? You said 1992 it started, good intentions, 50 hospitals qualified in the beginning or entities, covered entities. Was there a particular time when we started seeing manipulation of that program?
Yeah, it's been expanded both legislatively and administratively. Originally in the program, hospitals had to resell the drugs at the in-hospital pharmacy, but then it turns out some hospitals don't have an in-hospital pharmacy, so they allowed contracting with one external pharmacy. So a hospital could contract, with Joe's Pharmacy down the street or Walgreens or CVS. Then eventually they expanded that so it could contract with multiple pharmacies. And so now there's hospitals that contract with hundreds, even thousands of pharmacies, many of which aren't even in the same state as the hospital. I think there was some record of a hospital in Chicago had a contract pharmacy in Hawaii, something like that. So those were some of the expansions to the program. And then the child sites. Originally, child sites weren't included, and then that was expanded to include child sites. And then if you think in the broader healthcare policy landscape, with the expansion of Medicaid under the Affordable Care Act, that actually made it easier for hospitals to hit that dish percentage because now more patients were coming in with Medicaid and able to get admitted to the hospital, so they had higher dish percentages, so more hospitals could qualify. So there's been this huge expansion of the program. Just in terms of numbers, The total amount of purchases for 340B drugs in 2010 was as low as $8 billion. Dollars. In 2023, $125 billion worth of 340B drugs were purchased, which ends up being about $70 billion of a subsidy to the hospitals once you consider the discount and the resale price for those drugs. So hospitals in aggregate are making about $70 billion a year off of this program.
Okay. I wanted to imagine somebody who likes that program because I mean I obviously I'm with you, but I'm the host of the program, so I have to
Let's
imagine.
push back.
But I'm trying to imagine the pushback. And I'm
Yeah.
struggling in trying to understand what would somebody who really likes the program would come back at you and say, "Hey, you're completely wrong, Anthony." What would they say?
So look, I like the program and its intent. I work at a safety net hospital. I think that our hospital and our patient populations actually deserve this program and this discount. So I think that the program should be reformed so it's targeted more efficiently. If you want to take $70 billion a year out of the pharma industry and spread that around as a safety net grant that follows patients to safety net institutions, I'm fine with that. I think that would actually be a very valid use of those funds. I don't want to see my hospital destroyed by 340B reform. The problem is my hospital, which is 80+% Medicaid, gets the exact same 340B benefit as the hospital down the street that qualifies for the program that has a lobby that looks like a five-star hotel, with a harp and a fountain and all this. We get the same 340B discount. And I think that's mistargeted. I think that there is some legitimacy to this program. It certainly could help with access to medications. It certainly could help with that, quote unquote, stretching of scarce resources to safety net hospitals. I think it just needs to be targeted a little bit better.
So why it's not?
Well, there's a lot of hospitals making a lot of money off of it. And the problem is it's hard to see where the money's going. But again, if we want to look at some facts, there are some states that mandate a little bit of transparency. Minnesota is one of them, and they released a report on 2023 that shows a lot of where the funding is going. And I really applaud Minnesota for their effort in this. So they showed that uh, most of the recipients of the revenue for 340B were actually the large hospital systems that generate a large amount of revenue anyway. The safety net hospitals for 340B in Minnesota actually weren't generating much revenue. Again, because that comes down to if you're reselling these drugs to Medicaid patients, you're not going to generate much revenue at all. Whereas the large hospitals that generate the revenue are doing it by selling these drugs to wealthy insured patients. So this Minnesota report was actually very eye-opening for me. Showed that the large university hospitals made all the money, and the safety net hospitals made very little money, or even some of them lost money because if you purchase the drug and never resell it, then you're going to lose money on the program. So it's not being reformed because this has become a huge revenue stream for hospital systems. Right? If you're talking $70 billion a year, that's a huge amount of subsidy to hospitals. Now, if hospitals need a subsidy to keep their doors open, if they're saying, look, we are actually treating a lot of safety net patients and we need this subsidy to maintain operations, then let's have that discussion. Let's talk about a subsidy that could be targeted at institutions which see a large amount of low income patients that aren't making it so they can keep their doors open with Medicaid rates or with indigent care. And let's have that discussion, but let's not make it this weird financial arbitrage program that you make this revenue by reselling discounted drugs. Let's just make it a safety net grant, then we can have that conversation about a targeted subsidy.
But I think I think some of this is the metric of this inpatient stay. Because I mean, let's take an example. Let's say a hospital in a very affluent area, they meet that metric and they qualify for the program and they purchase the discounted drugs and they sell them at very higher premium. Well, by default, they're not going to have enough of this indigent patient population because the demographics that they serve is really, middle to upper socioeconomic class. So they can't really that metric is very one one time point that may
Right.
not always qualify. And you can't really help a hospital to serve these patients because these patients are not in the geographic area that they actually primarily serve. So I think the metric is completely flawed. If you put the metric based on zip code, I don't know. Maybe is that reasonable? Like if you say you're in the Bronx or you are in certain zip code areas in where you actually take care of patients or in New Orleans or things like that, where you have a higher, a majority of patients who are uninsured or underinsured or indigent patients, maybe that could be a reasonable start.
I agree. Like I said, I think if you want to take $70 billion a year and make a capped safety net grant that you can distribute, I mean, there's 1,001 different ways that you could distribute those funds better than the way the 340B programs currently does it, right? You could do it based on zip code. You can make it go just based on E&M. How much, what's your total proportion of E&M RVU that go towards low income patients compared to your total amount of E&M that you bill? If you want to incentivize opening up clinic spots, you could do it that way. I think in retargeting it, some other things that we should consider is right now the program really drives consolidation, right? So if you're especially in oncology, hematology space, and rheumatology, so any clinic that administers its own medications, if you're a private oncology clinic, you don't get that 340B discount because private independent practices can't. For-profit hospitals cannot get the discount either. So if you own a private oncology clinic and you're doing your infusions, you're getting reimbursed, but you're not getting a discount on those drugs. If large hospital system X then purchases your clinic without changing a single thing, all of a sudden, because you're now a subsidiary of that clinic, you get the 340B discount, and there's a huge amount of revenue. So there's plenty of data showing that this has driven consolidation. There's plenty of data showing that the oncology market, once practices are acquired by 340B, they start prescribing more expensive drugs because more expensive drugs generate more revenue. And there's plenty of data showing that this has driven consolidation and the use of higher priced drugs. So you could retarget it. So why shouldn't the independent physician-owned oncology clinic get this safety net grant or get some sort of bonus for treating low-income patients? Why is the hospital the only one that qualifies for this subsidy? Why not, the independent physician practice that is taking Medicaid rates and opening up its doors and making sure there's appointment slots for low-income patients? I think they should be eligible for this revenue as well.
But also, I mean, I think you hit the nail on the head, though, is it's probably part of the reason why a lot of hospitals are acquiring private practices.
Absolutely.
And when you're a private practice and you're operating on a thin margin, you sometimes have no choice but to sell.
Yeah, I mean, if the hospital doesn't buy you and they open up an oncology practice across the street that gets the 340B discount, or not even oncology. I mean, every practice, I'm sure your practice, you purchase
Yeah,
drugs and
no,
administer some drugs,
everybody.
right? Yeah, everyone does, even if it's just, lidocaine or something like that for your injections. So the fact that independent physician practices don't get this 340B subsidy creates a huge thumb on the scale in favor of these large hospital systems, and that a lot of that bears out in the data as well. Just some more stats because I love the stats on the program. IQVIA did a report showed that the 340B program alone costs about $5 billion a year in drug costs for self-insured employers. So this means your health insurance premium is about 6% higher than it would be if the 340B program didn't exist. See, a lot of times when I talk about this program, people don't like pharma. They say, "Oh, well, pharma just pays for it," but that's not actually true. The fact that you're taking these discounts, you're taking them from pharma and driving up the cost of drugs and driving up consolidation means that everyone is paying more. 340B hospitals charge about 8% higher prices than non-340B hospital. Outpatient clinic prices for 340B acquired clinics are 25% higher than outpatient prices in non-340B clinics. So this goes across everyone. Everyone's paying more money for the 340B drugs. Pharma tax revenue alone, the fact that we are taking taxable pharma profits and redistributing to non-profit, non-taxable covered entities, meaning that the federal government loses $14 billion a year just on the tax loss from 340B. So it's affecting everyone. It's not just pharma paying the price. We are all end up paying the price for it.
So is a lot of this the American Hospital Association just lobbying Congress and just like I mean, it seems to me that with proper education and dissemination of information, I don't think it takes a neurosurgeon, pun intended, to figure this out, right? That this is being abused. So is this just, Congress being bought by the AHA?
Well, I see it's hard because it's a very nuanced program. I think it's difficult for people to understand when you look at it on its face. Yeah, it's a drug discount program that goes to safety net hospitals. It's hard to argue with that. That looks really good. And to their credit, AHA is good at this at lobbying to keep this around. And I am actually a little bit sympathetic with Congress because if the biggest employer in your district is the large hospital, it's hard to be against them on this issue, right? I mean, just from a political, practical political standpoint, it's hard to go against the hospital on this issue. And this is one of the issues. I mean, the AHA is laser focused on this. This and site neutral payments, they will fight to the death on these two issues, and I don't blame them. Like, again, $70 billion is a lot of money.
Okay. Is there a path forward?
I think there is. Again, I think transforming the program so it's better targeted as a capped safety net grant. Again, if you want to charge pharma $70 billion a year, say we're going to take those funds, we'll put it in a capped safety net grant, and we're going to distribute that as a subsidy for institutions that serve low income patients. I think that is a much better way forward. Again, so you're not letting pharma off the hook. You're still making sure that hospitals which serve underserved and poor patients get a subsidy. Then I think you go back to the original intent of the program and you really do preserve it. You make it so it is truly helping the poor patients. Hospitals like mine can continue to serve poor patients and get a bonus for doing that from this safety net grant.
Are there efforts happening to try to get you from that point, from current point to point B that you just mentioned?
There are, and there's some good advocates in Congress. Senator Cassidy is chairman of the Help Committee, and he released a report on 340B, so they're raising awareness of it. There are some good champions in Congress about 340B reform. I was fortunate enough to testify in front of the House Energy and Commerce Oversight Committee, and there's certainly a lot of Congress people in there who have interest in reforming the program. So there is some
How
interest.
did
I
you
think
get to
people are.
testify? Why did they call on you?
I guess I've written enough on 340B in the past. It's gonna, once I realized what the program was, and there wasn't that many people speaking out on it. So I've been published in JAMA and Health Affairs on it. And so when they had a hearing, I was fortunate enough to be asked to come testify. And yeah, there certainly was some appetite for reform. I think there's some good advocates in both houses of Congress for this. It's going to be an uphill battle, and I think you're going to have to pair 340B reform with some other healthcare reforms. But I think I'm hopeful that there's a way forward. There's been multiple pieces of legislation that have been introduced over the years. And then administratively, the Trump administration has actually targeted 340B. In Trump 1, the first Trump administration, they actually took down the amount that Medicare would reimburse for 340B drugs. So right now, if you're an outpatient oncologist or whatever, and you distribute a drug, administer the drug in your clinic, Medicare pays the average sale price plus 6%. They call that ASP plus 6. And so again, that incentivizes more high priced drugs. The original Trump administration, they took that down from ASP plus 6 to ASP minus 22. That actually went all the way to the Supreme Court, and the Supreme Court overruled it, but they overruled it because of a process. They said that CMS didn't go through the appropriate process in making that change, but they didn't actually comment on 340B. So it had to go back to ASP plus 6. CMS actually had to repay hospitals that lost revenue. But that does show that there is an avenue that they could do if they went through the appropriate process. And then just recently, Harissa said that part of 340B could actually, instead of being an upfront discount, could be administered as a back-end rebate for drugs, specifically for drugs that fall under the IRA's drug negotiation provisions. So those drugs that are being negotiated by Medicare aren't supposed to get double discounts. And so the pharmaceutical companies raised the point and said, hey, if we are giving an upfront discount, but then we're also having a negotiated reimbursement from Medicare that's lower, then that's a double discount. And the Trump administration said, you're right. For those medications, you can instead give a back-end rebate instead of an upfront discount. So there's a little bit in the works. I think there's some interest.
So I want to just ask you just a more broad question, and I mean, why don't we teach students, residents, and fellows more policy? I mean, I think it seems this is like an acquired taste. I mean, I got interested in policy completely, like literally 10 years after practice and all of that stuff.
Same, same.
Yeah, I mean, it's like I had no clue when I was a resident and a fellow, any of that stuff. But I really feel the more I talk to people or interview people, there's total missing education gap amongst number one, the folks who are in training. And I also think people who are in the quote unquote ivory tower in academia sometimes, where they just don't really, they don't know these details. how can we educate the public more? I mean, let's be honest, not a lot of people are going to listen to our podcast together, but it is what it is. I mean, even if we get a few thousand people, that's nothing.
I agree. I think in the topic of broader medical curriculum reform, I will die on this hill that pre-med economics is far more valuable to the eventual practicing physician than organic chemistry is. There's some doctors will use organic chemistry, but I think basic economics would be a lot more useful to most of our practicing physicians and our patients. That being said, the med school curriculum is jam-packed. It's hard to fit in any of this. And I think the prevailing attitude amongst med students is be a doctor, become a doctor, become a doctor, become a doctor, get through med school, get through residency, put your head down, and then all of a sudden you're released to the wild and you're like, wait a second, why 90% of what I'm doing has nothing to do with patient care? It's all about checking boxes and computer work and answering these coding queries. I think that's when people start to realize. So I try to teach the residents early on. I'll have them code their own notes. I'll tell them why, how much RVUs they're leaving on the table when they miscode notes. Try to tell them about how the DRG system works. And I think we really have to just do it with real life examples because the residents do start to realize that when they're in the practice, like some of this doesn't make any sense. Why is it like this? And I'll try to work that into rounds. And we have our teaching series where I'll try to, not just teach them about how to treat traumatic brain injury and traumatic spinal cord injury, but every once in a while we'll have a lesson on, the history of the prospective payment system and the physician fee schedule and why we use RVUs and CPT codes. And I think there is some interest amongst residents, especially those. The other, big thing is that more and more residents, I think, with the pendulum is swinging back where they don't want to just be employed physicians. I think more residents are realizing, like, hey, I actually am interested in independent physician-led practice. And for those, I think there is a real interest in this because they do want to be able to own and operate their practice when they're done with residency. And to do that, they need to have an understanding of some of these market forces at work.
The other holistic question I have for you, and I think I'm 100% sure I've asked you this when we talked about Medicaid before, but I do think we need more people like you, genuinely, I say that, in politics where they just understand the you've got you rolled up your sleeves and you actually know the system and in running healthcare systems. And oftentimes, hospital presidents and people who are actually running the healthcare systems, most commonly they're not physicians. They could have a dyad who's a physician, but I mean, I've seen multiple structures where you still have somebody who's going to make that call for you. And also in politics, we don't have a lot of physicians who are really in Congress. Is this something that you have thought of? Because I know you're passionate about, or it's just the juice not worth the squeeze.
Well, I think personally, a path into politics is not for me. I live in I think a D plus 27 district, so that's not going to happen from my standpoint. But I think having these conversations is important. I mean, what you're doing is extraordinarily important, being able to have these conversations and get the voice out there. And you realize, I mean, this is tough, right? If you are a private practice physician, you're going to spend most of your time running your practice. It's going to be difficult for you to get out there and go to the meetings and advocate and, fly to DC and really, do the research to understand these topics. I mean, these are not simple topics, right? Learning about 340B, I've spent probably 5 years doing deep dives into 340B. It's insanely complicated. And that's just one small sliver of healthcare financing. PBMs, Medicaid financing, Medicare Advantage. There's so much in it that it takes a huge effort. And so if you're running a private practice, it's going to be very difficult for you to devote the time and energy to that. If you're in academics, you're probably going to be running a lab doing some basic science research or something like that. So it's very difficult to carve out this space. I think you're one example of success, obviously, but I think it's very difficult for most physicians to do that. I just got back from the PHA conference, Physician-Led Healthcare of America. There are more and more doctors that are running their own independent physician-led facilities, hospitals even, that are realizing that how important this is to get the word out. And they have events like the PHA conference, which I would highly recommend to anyone who's interested. They actually even have a med student chapter. So if you're a med student listening, you can look at creating a PHA med student chapter at your institution. where you can learn about the economics of independent physician-led care. And I think that really the only way is, drip by drip, bit by bit. Hopefully, more doctors will realize that there is something here that's worth, putting the time and effort into.
Anthony, anything else we should have covered about the program? Anything else we need to highlight to viewers and listeners that we may have missed that you'd like to leave us with?
Uh, like I said, it's an insanely complex program. It is integral to the financing of the safety net, and it's integral if we're talking about bringing back physician-led care. 340B and site neutrality are two huge revenue streams to these large consolidated hospital systems. And so, if we want to bring back independent physician-led care, we have to more evenly distribute those revenue streams so they're not just targeted and putting the thumb on the scale of large hospital systems. So, just big picture things. If you're thinking, why don't you see independent physician practices out there anymore? It's because they can't compete with these large hospital systems. They can't compete when the hospital system can make $70 billion a year on a 340B subsidy that's not available to the independent physician. They can't compete when the facility fees are, 10x at the large hospital system compared to what you get in your office or at the ASC. So there's this huge thumb on the scale on the side of the large hospital systems. It's incredibly complicated. It's incredibly nuanced. But we're simply not going to be able to bring back independent physician-led care if we don't take the thumb off the scale of these large hospital systems. And 340B is a huge part of that.
And I think you mentioned earlier, I want to highlight this again, so hopefully listeners really understand this. If you almost don't sell to the hospital, they will hire somebody else and they run the infusion center or they run they'll be
Yeah.
there with somebody, you know?
And it's inflationary. Think of, if you're trying to expand your practice and hire a partner, right? You probably can't offer the same starting salary that a large hospital can because they have this huge revenue stream. If you're trying to hire an MA or a nurse or even buy an x-ray machine for your practice, right? So these 340B and lack of site neutrality, site-specific payments have a huge inflationary effect on everything that you try to do for your independent clinician practice. So the price of everything you try to purchase goes up. The real estate goes up because the large hospital system can have these extra revenue streams that just drives up the price of everything. So it makes it, it's not just taking money from pharma and giving it safety net hospitals. It makes it more expensive for everything we do in healthcare.
This is amazing. I really thank you so much. I mean, I learn from you every time. Dr. Anthony DiGiorgio, thank you so much for coming on Healthcare Unfiltered.
Thank you for having me. It's always great to see you.